Welcome to Ultrasound Guided Vascular Access. I'm Charlotte Durr, and I'm going to provide you a guide to the real-time ultrasound visualization of central and peripheral venous vessels for IV cannulation. We're going to go everywhere from anatomic identification of these vessels on ultrasound, talk about the technique, all the way through to how to troubleshoot common pitfalls. So why use ultrasound for vascular access? Well, we know that different patients, they have different body habitus. So whether it might be an obese patient or one who's really muscular, it can be hard to use surface landmarks or palpation-based techniques to identify these blood vessels. Also, think about patients that come in with really low blood pressures, whether that be from hemorrhage, dehydration, or distributed shock. These vessels will reduce in size as the patient goes through volume depletion, making these vessels very much more difficult to palpate. We have patients that might have a history of IV drug abuse, where those vessels become scarred or even thrombosed. So it's important to use ultrasound to look and identify an appropriate blood vessel rather than accidentally cannulate a blood vessel that might have a thrombosis within it. Also, think about the patients who are at increased bleeding risk. We have lots of patients that are on blood thinner, which would make them more predisposed to bleeding. So if we, for example, accidentally stuck the carotid artery during an attempt to do a central line on an IJ, we would be holding pressure for a long time to prevent further bleeding. So rather than using simply a landmark or palpation technique, we want to use ultrasound to visualize that our needle is going into the correct structure, thereby preventing different complications. We also have patients that come in cardiac arrest or trauma patients that are very unstable that require first attempt success when we go to provide either a central line or peripheral IV. And we know that ultrasound increases the success rate of those procedures. So before we begin talking about the different techniques when it comes to vascular access, one thing to keep in mind is making sure you're selecting the correct transducer. So whether you're placing a central line or a peripheral IV, you're going to want to grab that linear array transducer, which typically has a range of 7.5 to 10 megahertz. The linear array provides excellent near field resolution for both superficial vessels and deeper vessels. It is ideal for the placement of an IJ or subclavian central venous catheter. It is ideal for a peripheral IV in the upper extremity. And typically the depth of a linear array goes to about 4 centimeters or a little bit more. So great for resolution, but better for superficial and not deep structures. For example, you wouldn't use the linear array to look inside the abdomen at the abdominal aorta, but great for those superficial structures. One thing to keep in mind, it's important to grip the transducer correctly. So the proper transducer grip is really the foundation for steadying your hand and being able to center the vessel on the screen and deliver the needle in or out of plane. If you have an unstable grip on the transducer, the probe is going to drift and it's going to be harder to stay centered on the vessel of interest, and it will make it more difficult for you to track your needle. So I recommend what we see here on the right hand side, and that's to anchor your hand and grip the transducer low. And think about using your fourth and fifth digit, almost like a little kickstand that helps keep you balanced on the patient. You will also want to use a light touch to avoid compressing the vein too much. You don't want to compress so hard that you obscure your visualization of the vein. So avoid the handhold that we see here on the left, gripping too high. And we want to see you stabilize your hand on the patient by gripping that transducer lower. It's also important to keep your ultrasound within your line of sight. You want to position the ultrasound screen so that as you're ultrasounding the patient and delivering that needle, you can simply glance up and see your needle pathway. You don't want the ultrasound screen set up behind you so that you're having to turn and crane your head around to look in the opposite direction. So position it in the line of sight. So for example, in this patient that's receiving a right IJ, you have the position of the ultrasound on the opposite side of the bed so that when you look up, you can easily watch your needle tip as it's being delivered down to the blood vessel. Also very important is image optimization. So you want to spend 15 to 20 seconds really optimizing the ultrasound image on your screen. So you'll want to adjust the depth so that the target vessel occupies the center of the screen. You don't want it too shallow or too deep. You also want to optimize your gain so that it's not too bright or too dark, but such that you can see that vessel, that fluid-filled structure. It should be dark on your screen without too many bright echoes inside. If the vessel looks too gray, then the gain is probably a little too high and you need to turn that down just a little bit. And then finally, take the time to center the target vessel on your screen. So the target should be centered on the screen before needle entry. And if you have it centered on your screen, then that's going to correspond to the center of that ultrasound transducer, which is where you will deliver that needle tip. So let's go ahead and go through an example here. So here we have our vessel on our ultrasound screen. So what is a way that you can make that vessel appear more ideal? Well, it looks to be very superficial. So one thing we would want to do is change the depth. So here we have that vessel. We're changing the gain. We're altering the depth to make it more towards the midfield. And then look how you can change the brights or darks to make sure that that vessel is appropriately anechoic. And again, as we mentioned before, we want the blood vessel on the center of the ultrasound screen. So the first thing that we're going to talk about anatomically is the IJ. The IJ is a very commonly cannulated vessel that we use for central venous access. And as you remember, no doubt from flashbacks from Netter's anatomy, the IJ runs lateral to the common carotid artery in that carotid sheath, and it lies anterior and lateral to the carotid at the mid-neck level, which is where we will begin looking with our ultrasound transducer to identify the IJ vein. And you'll notice that it's covered by the sternocleidomastoid mastoid. And if you were to follow it down, it joins the subclavian vein to form the brachiocephalic vein. Now, typically, we position ourselves at the head of the bed, looking down towards the patient's feet, something that looks like this setup. When I'm standing at the head of the bed, facing towards the patient and looking towards their feet, I keep my indicator pointing to the patient's left. I also keep it pointed to the physician's left on most other occurrences as well. So for example, if I'm at the bedside and I'm scanning the patient's aorta in the short axis, the indicator is kept to my left. If I'm doing a DVT exam over the femoral vein, the indicator is kept to my left. If I am scanning the IJ vein, I'm at the head of the bed looking towards the patient's feet, I keep the indicator to my physician's left. So whether it's to the patient's right, to the patient's left, that might vary, but if you always keep it to your left, you're usually going to have the indicator in the correct position. And the reason that's important is that when you slide left, the screen will slide left with you and not opposite to the direction that you're moving your transducer. So it's much easier to identify the vessels in their transverse orientation. So in doing so and having your indicator pointing to your left or the patient's left, the first thing that you'll see here on your screen is a short axis view of the carotid artery, and then lateral to that will be that internal jugular vein. And whether those vessels are side by side or slightly overlapped often depends on whether or not the patient's head is rotated. So other than anatomical position, how else might you be able to recognize a vein versus an artery on ultrasound? Well, the arteries are typically a little bit smaller and they stay very round in their cross-section even when pressure is applied. They should be pulsatile and you might see the arterial wall move with each heartbeat, and they're generally non-compressible under probe pressure versus veins, which are generally collapsible. The artery is also going to have a thicker and brighter wall, more so compared to the vein. So the veins tend to be larger or often more oval or regular in shape, very easily compressible with probe pressure. If you had the patient take a deep breath and hold their breath, or even Valsalva, that's going to make that vein even more prominent, maybe a little bit bigger. And if you're to watch the vein, it'll show what's called some respiratory variability in size as the patient is breathing in and out. If you were to use color Doppler, as you can see being applied here in the lower left image, blue away, red towards. So color Doppler is going to show you what is coming towards and away from your probe and assign it a color. So if flow is moving away from the probe, it is going to be blue, and towards the probe is going to be red. So we can see here in this example, blue away, red towards, the vein is blue, the artery is red. But you could change that and flip the colors just by the way that you're fanning the transducer. So just because it's blue or red doesn't mean it's a vein or an artery. It has to do with which way the angle of inclination of that ultrasound beam is being held, such that the Doppler detects flow either towards or away the transducer. And here in the upper image, just showing the great collapsibility here of the IJ as opposed to the carotid that does not collapse under pressure. Another thing I like to do when it comes to looking at the IJ vein before I cannulate it for central venous access is just determine how straight the vein runs. So after identifying it in the short axis as we see here, I'll rotate the transducer 90 degrees and look at it again in the long axis plane. Rotating between the short and the long axis only takes a few seconds. It allows me to ensure that my target vessel travels relatively straight so that I know when it comes to the procedure, I shouldn't have any difficulty cannulating the vessel. There are some instances where there will be some branching of the different venous anatomy, which could cause problems when it comes to threading your catheter later. So it's nice to be able to identify that that vessel is running nice and straight before you get to that step. Another thing that I recommend before you get set up to do your central line and take that time to do the sterile prep and apply the sterile setup and drape is to look at that IJ vessel before you leap into the setup. The reason being is you want to not only confirm the anatomic relationships between the IJ and carotid, make sure that IJ runs straight, but also to rule out pre-existing thrombosis. So if you take a look here, this image on the right, here's the IJ vein carotid. What do you see inside the lumen of the IJ vein but a big thrombosis? So this patient has an IJ DVT. We would want to avoid that site and go check out the other side of the patient to see if they had a patent IJ. We don't want to be putting a central line through a thrombosis. The other thing that the pre-scan does is it allows us to note the vessel depth and size. Do I have a good IJ diameter such that I'm going to be successful with the procedure? What is the depth that I'm going to be anticipating cannulating that vessel? In some patients, the vessel is very superficial. Others, it might be a little bit deeper. You can use your caliper markings here on the side of the ultrasound machine. Here is 1 centimeter, here's 2 centimeters. You can see that total depth is 2.6 centimeters. So it allows you to know exactly how deep you will be performing the procedure. So go ahead and do that pre-scan before you move to the next step, which is going to be to go ahead and get that sterile field set up. So you're going to need a sterile transducer cover. You want to have the patient in your ultrasound screen already in position, and make sure you have some sterile gel. So it doesn't matter if you have sterile gel on the inside of the transducer, but you need sterile gel on the outside within your sterile field. So when it comes to preparing this transducer for central venous access, you can put sterile gel on the inside if you've already set up your sterile drape and sterile field. You could have pre-gelled with non-sterile gel prior to the procedure, but it's easiest to go ahead and use that sterile packet to go ahead and put both gel both on the transducer and then cover with a sleeve, and then finally that gel on the outside of the sleeve as well. As you're putting the transducer into the sleeve, you want to make sure you eliminate any air bubbles because that's going to be causing an artifact on your ultrasound machine. Once you secure the sterile sleeve with rubber bands, then apply that sterile gel to the outer sleeve surface so that everything stays sterile in your sterile field. We always want to make sure we're using plenty of ultrasound gel on the patient as we're scanning, which will improve your image. So once everything is ready to go, rubber bands are on, do one last look to make sure you've eliminated that air from that interface, because having air pockets in between that ultrasound transducer and sterile sleeve is going to create some significant reverberation artifacts that's going to obscure your image as you're scanning. All right, so next we're going to talk about transducer placement. Where do we start? What should we expect to see on our screen? Hopefully you have already pre-scanned this patient so you know where your initial probe position is going to be, but you're going to place the now sterile transducer directly across that sternocleidomastoid muscle to see those vessels in their short axis and identify that IJ. Again, it's going to be very collapsible. It's not going to be as round or have as thick a wall as the carotid artery will. The carotid is often smaller, more rounder, and will be pulsatile as compared to that IJ vein. Remember, that IJ vein is going to be nice and collapsible. When it comes time to actually delivering the needle and doing the procedure, you're going to want to swap the transducer to your non-dominant hand and use your dominant hand for delivery of that needle. And remember, hold the probe low down near the neck of the probe, stabilize your hand using the 4th and 5th digits to help keep your hand steady so that you have less movement, less wobbling during the procedure. Now, there are a couple different ways to perform the procedure, something called an in-plane and an out-of-plane technique, and we're going to cover those next. The in-plane technique is actually used less commonly than the short axis or out-of-plane direction technique, but let's just start here with the in-plane technique. In the in-plane technique, you will visualize the long axis of the IJ. So remember, we started with the identification of the vessels in their short axis. So by rotating the transducer 90 degrees, keeping the probe indicator pointing towards you, towards the head of the bed, you're going to see that vessel running as a long anechoic channel across the length of your screen. When you do this in-plane technique, you're going to see your needle enter right next to the transducer, and you're going to enter at a very shallow angle of entry, which improves the needle visualization as you're traveling towards the vessel. The key advantage of the long axis in-plane technique or for the short axis out-of-plane technique is that ability to watch the entire visualization of your needle tip from skin entry all the way down to penetrating the vessel wall. So it essentially eliminates the risk of overshooting and accidentally going through the posterior wall of the vessel. But the technique requires you to visualize the entire needle shaft throughout the entire procedure. And you have to be directly under that ultrasound beam. So it does require really good hand-eye needle coordination. Using this image as an example, as you're entering in plane over the long axis of the vessel, you should start to see the echogenic needle tip as it comes through the skin, soft tissue, traveling down into the lumen of the blood vessel. Let me show you another example. This is a phantom image where we can see the entire extent of our needle as it passes through down into the anechoic vessel. So that's really the benefit of this long axis approach, is seeing the entire needle path. Nice long echogenic needle coming down through soft tissue into the vessel, but it does require a higher level of psychomotor skill. So think of the ultrasound beam in this technique as being thin as a credit card. It's only 1 to 2 millimeters thick. So if your needle deviates even slightly from underneath that very thin ultrasound beam, it's going to take it out of the image and you're going to lose the needle. So you have to have very steady hand and be very, very accurate in delivering the needle under that ultrasound beam and staying under that ultrasound beam. So some tips and ways to make this successful is to enter with a very shallow angle. It will make your needle appear brighter and it will be easier to follow on the screen. So start close to the transducer, enter at a shallow angle, and then advance very slowly. And you don't want to keep advancing if you don't see your needle tip. If you don't see the needle after you enter the skin, you need to fan your ultrasound beam and find the needle tip, and then figure out, am I a little bit to right? Am I a little bit to the left? More medial, lateral? And then you will back your needle out and then readjust appropriately. If you are outside the beam, then what you'll see is the indentation of the soft tissue, but not the needle tip. So make sure you have good visibility of the needle before you carry on through there. So that's what we want to see, is the entire extent of our needle as it crosses and travels towards the vessel. So here's an example on the left where initially you see the indentation of the tissue but not the needle. So the operator had to fan back, find that needle, and realign before entering down into the IJ. So what does this look like on a phantom? Over here on the phantom, you can see we're coming through at a very shallow angle. And what that does is provide you that ability to see that needle tip and makes it very bright at a very low angle of entry. The more parallel you are to the ultrasound beam, the brighter your needle is going to appear on ultrasound when using this in-plane long axis of the vessel technique. So keep those things in mind. All right, now we're going to talk about the short axis, out of plane approach. So this is where I really want you to pay attention, because this is the technique that's used most commonly by physicians, by your peripheral access team, by nurses, by paramedics and techs who do ultrasound guided vascular access. This is where you're going to start. This is what your first approach and first learning technique is going to be. So you are short axis to the vessel. So you're going to see the vessel as a circle, which is why it's called a short axis technique. And you are out of plane with the ultrasound beam itself in this technique. So typically you're going to visualize that vessel on the short axis. You're going to keep the probe marker to your left, as we have already discussed. And you're going to see that anechoic round vessel. In this case, we're talking about central venous access. We're going to identify that IJ lateral to the carotid. Now, the trick is having a really good idea about how to do the needle entry and how to follow the echogenic tip of that needle. So the needle is entering the imaging plane, out of plane, and it's only going to be detected once it crosses underneath the ultrasound beam, and it's going to be seen as a bright echogenic dot. We'll blow up this image in just a moment as it goes under the ultrasound beam. Now, this one is probably easiest to learn, but it can be hard to really perfect your technique in doing this. So tip control and the ability to follow the tip of your needle is key here, because you want to make sure you don't accidentally lose track of your needle tip and penetrate the posterior wall of the vessel. So let's blow up this schematic and look a little bit more closely. So your needle is crossing under the ultrasound beam, and when it's cutting the needle, it's only going to see a little tiny representation of the needle. Because you are out of plane, you're only going to see that needle in cross section, and it will only be seen as it passes under the ultrasound beam, a bright little dot with a little bit of reverberation artifact. So how can we do this technique and be successful with this technique? First, make sure you have the vessel centered on your ultrasound screen. So before you enter with your needle, center the IJ on the ultrasound screen. The center of the ultrasound screen corresponds to the center of the transducer, and that is where your needle is going to enter the skin. Okay? Now remember, you're only going to see that needle after it passes under the ultrasound beam, and it'll be seen as a bright dot. And that's only when it intersects the imaging plane. So if you enter the skin and you do not see that echogenic dot that represents your needle, you need to slide your transducer or angle that ultrasound beam towards you, towards where the needle is entering, until you see the bright dot that represents the needle shaft. Now, as you were sliding your transducer away and advancing your needle forward, once that needle tip comes into contact with the IJ, you should see some compression of the IJ wall to let you know that you are about to enter the lumen of the vessel. So remember, the needle must be tracked carefully to avoid advancing the tip beyond the visualized plane. So let's go ahead and talk about the common pitfalls in this technique. The most common pitfall of the short axis out of plane technique is confusing the needle shaft cross section for the needle tip. In other words, you see a bright echogenic dot on your screen and you think you're following your needle tip when in fact your ultrasound beam is crossing the shaft of the needle. So the ultrasound beam, it's going to intersect the needle at whatever point the beam is positioned. So a bright dot on the screen means the beam is crossing the needle somewhere, but not necessarily at the tip. So what is the solution to this common pitfall? You need to track the needle very patiently by sliding the probe distally as the needle is advanced. And in effect, you're chasing the tip of the needle. And I'm going to show you a video demonstrating this in just a moment. So if you identify the needle and then advance the probe, find the needle, advance the probe, find the needle, you will be very successful in this technique. So the hands have to work together. Both the probe hand and the needle hand have to work together to either slide or fan, and using that technique to ensure that the most distal visible dot that you're seeing actually represents the true tip of the needle and that you're following that true tip of the needle down towards the vessel. We want to make sure the hand is working with the needle hand and the probe hand, that they're working together, so that allows you to chase the tip. So you can do this in a couple different ways. You can either slide, find the needle, slide the probe hand away, and then advance the needle hand. Slide the probe, advance the needle, slide the probe, advance the needle. Or you can do more of a fanning technique, which is what I'm going to show you in the next video, where you fan the probe towards and away that needle entry point while keeping the transducer footprint more stationary, but you're fanning the transducer to follow the needle tip. That also works. Or you can use a combination of both the sliding and the fanning technique. So let's start with a fanning technique. Let's go ahead and get to that video here. So watch the probe hand. The probe hand is being very dynamic and it's working with the needle hand. Look at the fanning that's taking place so that the operator is able to follow that bright little dot down into the vessel centered on the screen. So these two hands, they are working together. A common mistake for novice users is that the probe hand stays anchored on the patient and it's perfectly sedentary while the needle advances and does all the work. This probe hand has to work. It either has to fan and follow the needle tip or slide, which is the next technique I'm going to show you, so that you can properly follow the needle as it goes through the soft tissue. All right, so here we have the probe hand sliding away while the needle hand advances. So they're chasing each other. Probe hand slides forward, needle catches up. So the probe goes forward, then they find the needle in the soft tissue, and then they slide the probe away and then find the needle tip. So they're chasing each other down to make sure we watch that echogenic needle tip just as it's entering the vessel right there. You can see that nice little echogenic needle tip with ring down artifact. So that is the slide technique. I'm going to re-emphasize again to make sure you are centered under the ultrasound transducer. Your ultrasound transducer will have a mark letting you know where the center of that transducer is. You should enter under the center of the transducer and make sure that you keep your vessel centered in line so that you know that when you enter under the transducer center that you will be able to follow that echogenic needle tip towards your vessel that has been centered on the screen. Okay. So center that vessel before you get started with your procedure. I also like to use the M mode line to help keep myself centered. So how does that work? Once you find the vessel on the short axis, All of your ultrasound machines will have an M mode function. And when you touch the M mode, it will bring up a vertical line on your ultrasound screen. And if you can keep your vessel centered on that vertical line, that means that you are under that middle part of your ultrasound transducer. So that can really help keep novice users in the right area, right below that beam, so that they are most successful in entering the blood vessel. It really takes out the guesswork about where the ideal skin entry point is. So here is what that M line looks like. It'll appear slightly different on different ultrasound machines. It will default to the center of your image when you first turn it on. There is a way to drag it right to left, but we want it to be right in the center of our ultrasound image. And if our vessel is centered on that green line, then we know that when we enter under the middle of our ultrasound transducer, that we're going to be heading towards our target vessel, and we'll have everything aligned up appropriately. So let's go over a couple more tips and tricks for making sure our central venous access is successful. So at some point, you're going to encounter a challenge when it comes to ultrasound-guided central venous access. Tip number one, always confirm before advancing. So after you enter the soft tissue, make sure you see the needle tip and you have found that needle tip on your ultrasound screen before you advance the needle further. So never advance a needle you cannot see. You want to stop, realign if necessary, confirm your location, and then the right and the left hands work together to follow that needle through the soft tissue. If you lose your needle on either axis, short or long, you can always rotate 90 degrees to verify where the needle tip is, because sometimes where the tip is in the soft tissue can be hard to recognize. So having that dynamic ability to switch between long or short axis will help resolve the localization issue when it occurs. And finally, before you pass the guide wire, go ahead and confirm the needle tip position in the two different planes. So whether you started in a short axis or long axis approach, rotate the 90 degrees, make sure you haven't accidentally gone through the back wall of that vessel before you place the guide wire. So confirming before that wire is super important. And then even after you pass the guide wire, I recommend keeping the ultrasound in your sterile field. Verify that that wire had no problem entering the vessel before you cannulate with the larger catheter. So let's say you are in the longitudinal in-plane approach and you lose needle visualization. So first thing I would do is either fan or slide the transducer to the right and to the left while you hold the needle still. After you fan and you find the needle, was it too lateral? Was it too medial? You'll bring, let's say it was too lateral, you'll bring your transducer beam back over the vessel and then pull back the needle, which was too lateral, and then realign it with a little bit more of a medial position. So small probe adjustments, allowing you to sweep and find your needle, and then realigning to the proper position, it will really help. The other thing is to don't go in at too steep an angle, right? Nice superficial angle makes that needle brighter and easier to follow. So keep that more shallow angle relative to the skin and allows for a more parallel trajectory. Makes it easier to see going through the soft tissue. And as we said a little bit earlier, if you lose sight of your needle tip, you can simply rotate 90 degrees. In this case, you would be going from a long axis to a transverse view. Rotating that probe might help you better identify that needle. In this case, it would be a bright dot once you rotate to the transverse view and allow you to see where you might have deviated more laterally or more medially, allow you to pull back and correct. So that's how you troubleshoot the longitudinal approach. What if you're in a transverse short axis out of plane approach and you lose your needle tip? Well, remember, we don't want to continue to advance that needle tip blindly. So think about sliding the probe towards you or away from you, using maybe even a little bit of a fanning motion in addition to the sliding motion to help you find that needle tip in that soft tissue. Remember, we're looking for a bright echogenic dot that's going to appear as the beam crosses the needle. The bevel tip of the needle produces a bit of a stronger reflector, so that might help you identify the most distal point of the needle. The most echogenic point will be that tip. Now, you could have an issue as you're trying to pass the guide wire. So let's say you're in the out-of-plane approach, you've aspirated blood, you're going and you're threading your guide wire, but it's not advancing freely. Keep the ultrasound in your sterile field. Grab it and then go back and check where your needle tip is. Is the needle tip still inside the vessel lumen? Could it have gone through the back wall of the vessel? And that is why the wire is not passing appropriately. So use your resources, use the ultrasound, keep it sterile in your field, and confirm the tip location. And you can rotate between the short axis and the long axis before reattempting the wire passage. So we just spent a few minutes talking about central venous access. Now we're going to take those same skills and we're going to apply them to peripheral venous access. So think about the patients that come in. We have lots of patients that have reasons for difficult peripheral access. Somebody has attempted peripheral IV. They haven't been successful. They grab the ultrasound. What targets are they looking for? The most common targets will be the brachial vein, which you'll find in the middle upper arm, the basilic vein, which is a little bit more medial, or the cephalic vein, which is a little bit more lateral upper arm. There are some alternative sites we use, but not primarily. That would be the external jugular vein, great saphenous vein. Typically don't use those too often. More commonly, we're looking for that brachial, basilic, or cephalic vein. So it's important to have the right setup. You want to make sure that you take time to grab a table, take the arm, stretch that out on that table, have your ultrasound in your field of view. You're still going to be using that 7.5 to 10 megahertz linear array transducer. Unlike a central line, you're not really required to have a sterile sleeve, but you still want a sleeve cover over the ultrasound. So a non-sterile sleeve cover is perfectly appropriate. Position the arm extended. Make sure you're using a tourniquet to make that blood vessel even bigger and easier to identify and cannulate. And place that ultrasound right in your line of sight. So all this in the setup is really, really, really important. And next, you'll start scanning the arm, looking for the basilic, looking for the brachial vein, looking for the cephalic vein. You want to see what your options are. So how do you select the best vein for peripheral IV access? Ideally, we want a vein that's got a decent size diameter. So larger veins are going to more readily accommodate these longer IV catheters that we typically use for ultrasound-guided peripheral access. And a diameter greater than 3 millimeters is generally preferred. In fact, I might even suggest you go for something greater than 5 millimeters, and you'll be able to see the size on the ultrasound machine, and you'll be able to recognize whether it meets that 3 to 5 millimeter cutoff. So I think when you're first starting, it would be smart to use a cutoff of greater than 5 millimeters. The other thing that you want is something that's not traveling right next to an artery, because that would increase the risk of accidental arterial puncture. So the ideal vein is going to be large and nowhere near an artery. We would also love a vein to be really superficial, right? It's going to be more comfortable for the patient if it's not a deep vein. And veins that are deeper than 1.5 centimeters from the surface tend to be at higher risk for catheter dislodgement. So we would love to have something that is fairly superficial and also one that is running rather straight. We have a vein with a straight trajectory. That also is going to make the procedure more successful, as tortuous veins or those that curve might impair our ability to advance the catheter appropriately and therefore would increase our likelihood of having a failed IV. So what do you think about this vessel? This vessel is 0.5 centimeter. You can see that this is a 0.5 centimeter, 1 centimeter, 1.5, 2. The whole depth is 2.2 centimeters. Nice vein, it's nice and collapsible. Do you see any arteries nearby? I see no arteries. It is the lone vessel on the image here. It is superficial. And the next step I would want to do is estimate the size and see if it runs straight. Because if so, we might have ourselves in an ideal vein. So what do you think the size of this vessel is? If this is a 0.5 centimeter, it's certainly not greater than 5 millimeters. It's probably close to that 3 millimeter cutoff that we described earlier. So I would certainly not recommend you going for anything smaller than this target right here. But this target is nice in that it's superficial and nowhere near an artery. And we would want to rotate or follow it up and down the arm to see if it also runs straight. Once you find an ideal vessel, then what is the setup that needs to take place? So we typically use longer angiocatheters, so usually 1.88 inches or longer, which allows you to get into these deeper veins. So one of the things we worry about is if we put a catheter in and we don't have a long enough catheter, that with the elastic recoil that occurs once you take the probe off the skin, that catheter might slip out of the blood vessel. So we typically use longer IV catheters. You're going to prepare the skin, usually with chlorhexidine. You don't need a sterile drape, but we do use clean covers to keep the blood off of the ultrasound transducer. So you're still going to use a sleeve, even though it's not a complete sterile setup. And just as we discussed with central lines, you're going to identify the vessel and mark and notate that anatomy using your dominant hand. But when it comes time to actually cannulate the vessel, the ultrasound itself will be held in your non-dominant hand, and your dominant hand will be used to deliver the needle. So let's talk about going ahead and delivering that needle. What happens along the way? How is it different than a central line? So when we deliver the needle for peripheral access, we're going to use the out-of-plane short axis approach to the vessel. Again, you can use in-plane or out-of-plane, but the most common approach at most institutions, especially when you're first learning, is going to be using a short axis out-of-plane approach. And in that approach, you typically insert your needle at about a 30 to 45 degree angle of entry into the skin. And then as you work your trajectory towards the needle, the right and the left hand are going to work together to follow that echogenic needle tip down towards the vessel. You will be able to visually see and confirm vessel entry on your ultrasound screen, but also looking down at your angiocatheter, you're going to notice a flash of blood that comes into the hub of that angiocatheter that will also confirm that you're in the correct intravascular position with your needle tip. Once you have confirmation, you'll be able to advance the catheter. You can do this without continuing to hold the ultrasound transducer. So between the insertion, following your needle tip, and confirming your vessel entry and seeing that flash of blood, once you have the confirmation that you're in the vein, you can set the ultrasound transducer aside and then thread in that catheter with your fingertip. So feel free to set the probe aside and go ahead and perform your blood draw and secure the IV as appropriate. All right, so let's go ahead and look at a video demonstrating this. So first I want to point out the angle of entry into the skin in the short axis approach at a 30 to 45 degree angle in that plane that's going to be directly under the middle portion of that ultrasound transducer. You have centered your vessel onto the middle of your ultrasound screen. You are taking an out-of-plane approach, which means you should just see a small echogenic dot as it passes through the soft tissue towards that vessel. The probe hand and the needle are going to work together to follow the tip of the vessel through that ultrasound screen visualization of the soft tissue until you enter the vessel here. So here comes the needle under the skin. The needle is, you see a little bit of skin tenting, and then the needle is quickly visible there entering that soft tissue. Once you have seen confirmation on the ultrasound screen, you're going to get that flash of blood, which you're going to see in this angiocatheter in just a moment. At that point, you can put the ultrasound transducer aside. The individual performing the procedure here kept the ultrasound transducer on the patient's skin, but I recommend setting the transducer aside, and that way your right hand and left hand can work together to successfully deliver the angiocatheter under the skin. But you'll see there's that flash of blood in the hub, angiocatheter is going in, and at that point, you are ready to secure your IV or draw black blood. So no need to continue to handle the ultrasound transducer at that point. So what are a few tips for successful peripheral IV placement? First of all, this is a common mistake I see. Don't forget to put on that tourniquet. That's really, really important. And put it up as close to the patient's axilla as possible. Using that tourniquet is going to allow you to maximize venous distension, and that's going to increase the blood vessel size. Having a larger blood vessel dramatically improves your chance of first pass success at this procedure. Also make sure you're using a long enough angiocatheter. The shorter angiocatheters that are used for cannulating vessels from the elbow, forearm, down to the wrist, those are going to be too small. We want the longer angiocatheters, and that's going to prevent the catheter tip from accidentally backing out of the vessel during the procedure after the patient moves their arm. So we want to make sure we have a long enough catheter to be using in this procedure. Also, think about minimize your transducer pressure. We know that having just a little bit of force with that transducer collapses those veins, especially the more superficial veins. But even sometimes those deeper veins can collapse with just a little bit of pressure. So use a very light touch with that ultrasound transducer on the skin while performing this procedure. Always make sure that you take the time to look around for any neighboring arteries, as well as confirming that the target that you have in mind is truly a vein and not an artery. So think about using compression. Veins should be compressible. If you want to add some color or pulse wave Doppler ahead of time to confirm that it's a vein and not an artery, that's also fine. Just remember that inadvertent arterial puncture with these larger angiocatheters can cause problems with hematomas, and large hematomas can even potentially be limb-threatening. So we really want to make sure that we've identified a vein and not an artery. Finally, take the time to optimize your ultrasound machine, set the depth, change the gain if you need to, and center that vessel for the best success. Well, I hope you've learned something from this lecture. Please feel free to reach out if you have any questions. My email address is at the bottom of the slide, and I wish you great success when it comes time for you to perform your next central line or peripheral IV. Take care and happy scanning.